Good afternoon, everybody. Thank you for joining us today for our policy forum from crisis to care, a policy forum on maternal mental health. Happy Mental Health Awareness Month. We're really excited about this timely policy forum and excited that we're going to have the next hour to delve into this topic with our wonderful panel. We have a really special panel for you today. Individuals I've known personally for a very long time and some new faces too coming to this topic issue topic from all different places in the healthcare system. So really excited for our conversation today. All right, next slide, please. Want to give a shout out to Promise Health Plan. Thank you so much for your generous sponsorship of this event. We always appreciate their partnership. All right, next slide, please. Thank you. Okay, so a few things, housekeeping. I realize I just haven't even introduced myself, so probably should do that. I am Jana Wright. So Jana, like Hannah, the Director of Policy here at Insure the Uninsured Project. If you're unfamiliar with our acronym, it's pronounced ITUP. So happy to have you here today. I've been working in health policy for the past 11 years now with a focus and emphasis on maternal child health. So this policy form in particular is very near and dear to my heart. I am part of the population that suffer with postpartum depression personally, and just understand how essential the supports can be during this really vulnerable time in people's lives. So really hope that you are buckling in for today's policy form and that you are able to be attentive and really give it the attention and respect that this topic deserves. All right, some housekeeping though. The first one is this session is being recorded. So the meeting, the links and resources will also all be emailed to you, the participants, and they will be posted on the ITUB website after the meeting. So if there's a link that you didn't get to write down, that's okay. We'll have that all posted for you. So just sit back and enjoy. Closed captioning is available. So you can enable closed captioning by selecting the CC or transcript icon from your toolbar. Submit your questions at any time during today's webinar using the Q&A function on your screen. And the chat is open and we encourage you to engage throughout today's discussion. Feel free, I know some of you have already started introducing yourselves in the chat. Feel free to do so. We'd love to see who's all in the room. All right, next slide, please. All right, I already did this. This is just my headshot. Thank you. All right, so our agenda for today, I'm going to run us through our welcome and introductions, and then I'll pass it off to Rana Sullivan, who is going to be our moderator for today's panel. And she'll introduce everyone on the panel and get into our discussion questions, and then we'll end with a wrap up around 1:55. All right, next section, next slide. Okay, so just want to set the context for us really quickly. So like I said earlier, many people are impacted by mental health conditions. This is 1 in 5 mothers are impacted by mental health conditions. We know that this counts for 22% of pregnancy-related deaths. Mental health conditions are a leading cause of maternal deaths, in particular suicide. Next slide, please. So if you hear someone say 1 in 5, that's what they're referring to. Barriers to accessing care. That probably makes a lot of sense to you, but feelings of shame, stigma, and guilt, expense, and/or a lack of access to healthcare, social biases in the healthcare system, logistical challenges such as transportation or childcare, distrust of the healthcare system, fear that the Child Protective Services or immigration agencies will become involved. We've seen a lot of that this year with ICE coming into neighborhoods. And then also fear of being considered a bad mom. Racial, cultural, and religious beliefs play a role too. We also know that 10% of fathers do experience postpartum depression. We know that if mom is experiencing depression, dad is 50% likely to be also experiencing postpartum depression. So you can imagine what that would do for the child's development during that crucial period of their life. We also know that women of color and women of low incomes are more likely to experience maternal mental health conditions and are less likely to be able to access care. All right, next slide, please. I really just want to talk about the cost of these untreated maternal mental health conditions. So the cost of not treating a maternal mental health condition is $32,000 per mother infant pair or dyad each year in the US. $32,000 per year This is $14 billion is the cost of untreated maternal mental health conditions. You can imagine from a healthcare system standpoint, this can lead to things like costly inpatient care, also lead to things like extended hospitalizations that really drive up the cost of care. Individuals can feel overwhelmed, have these negative thoughts, depression, anxiety. There's a whole realm of what we call perinatal mood and anxiety disorders we'll talk about, but we also want to include psychosis in today's conversation. All right, next slide, please. I think this is when I'm passing it off. I'm going to pass it off to Rana Sullivan. She is the Senior Director at Transform Health, and she's going to be our moderator for today's upcoming panel. So, Rana, feel free to take it away.
Thank you, Jana. I really appreciate the warm welcome and good afternoon, everyone. Thank you for joining us today for this important conversation about maternal mental health policy. We have a panel of incredible experts and thought leaders here to share their insights and experiences. As Jana noted, maternal health disorders during the perinatal period before, during, and after pregnancy are among the leading complications of childbirth, impacting many birthing people, yet often going unspoken because of stigma or lack of supports, whether those are family, clinical, or political supports. Our goals today are to open up this conversation on how to improve maternal mental health equity and outcomes. So we'll explore the connection between maternal mental health and overall maternal and child health outcomes, learn from experts about successful strategies to integrate mental health support into maternal care, hear firsthand experiences from individuals and providers working to address mental health challenges during the perinatal period, and leave with actionable insights to advocate for improved maternal mental health policies and programs. As Jana noted, we'll have time at the end for questions, so please do drop them in the chat as they come to mind. And now I am pleased to introduce our panelists. We're joined today by Sherry Callahan, who is a manager at Blue Shield Promise, overseeing the initial health appointment and comprehensive perinatal services program. Dr. Kiana Gaunt, a medical social worker at the Veterans Health Administration and professor in the Department of Social Work at California State University, San Bernardino. We're also joined by Mia Hempstead, a communications director with Maternal Mental Health Leadership Alliance, and Kelly O'Connor, who serves as executive director of Maternal Mental Health Now. Each of our panelists brings a wealth of knowledge and experience to this topic, and I'm so excited to dive into some of the critical issues around maternal mental health policy in our current landscape. So with that, we're going to jump into the first question, which is, why is maternal mental health an important issue today? So we will start with Sherry. Please take it away.
Thank you. I'm happy to be here today. I think this is so important because it affects so many women, and 1 out of 5 women is a huge amount. And I think 75% of those actually go untreated. And there are a lot of things we can't change in this world. And I think that this is one thing we do have the power. There are a lot of challenges, but I think we can make a difference. So that's why I think it's important.
Sherry. And then Dr. Gant, we'll move on to you.
Hello, everybody. This is especially important to me because I am a mother and experienced postpartum depression. I had no idea of how to articulate what I was going through, and I believe a lot of women who are experiencing postpartum don't know how to truly articulate it, to even express this is what I'm going through, so providers know. So this is why it's especially important to me and why I want to speak out and shed awareness.
Dr. Gant, for sharing your experience. Mia, we'll move on to you next.
Thanks. There's so many reasons I feel like this topic is important. I mean, I think one of the most alarming ones is the fact that suicide and overdose are a significant leading cause of death, accounting for 22%. I think we saw that number earlier. 22% of all deaths of moms every year. It's like if you think about all the maternal mortality happening in the US, about a fifth, a little more than a fifth, is because of suicide and overdose. In my work as a communications director, I have to read the articles that come out, whether they're from small regional news outlets to the New York Times, of when a mom takes her own life. And it's part of my job, and it keeps it very front and center and fresh in my mind of just how many people are suffering. And once that mother is gone, she's gone forever. And now that family and that child have to figure out how to grow up and heal. And I think this is one of the number one preventable illnesses that we can treat. Like Sherry was saying, we have the power to do something about this. So this is an unnecessary tragedy that is inflicting our country. And I also personally went through both postpartum anxiety and depression, and I didn't understand about it. And we have so much more awareness now than when I gave birth 8 years ago. But I learned about postpartum depression standing by the copy machine at work, having a conversation with a coworker who was waiting in line to make her copies. And she was like, are you going to take leave? And I was like, yeah. And she was like, I thought I was going to take a long leave too, but I ended up coming back. Oh, why? Because I had postpartum depression. And I said, what's postpartum depression? And I was 8 months pregnant. I had never heard about it. So there's a lot of reasons why I'm fired up about this issue, and those are just a few.
Yeah, I have chills from the statistics that you shared. And then Kelly, we'll move on to you next.
I think what hasn't been said yet is when you have depression or anxiety during pregnancy, that can lead to preterm labor, low birth weight babies, and poor birth outcomes. When you have depression or anxiety during the postpartum period, it disrupts the bonding and attachment that's supposed to happen between the birthing person and their child in that first year of life, which then sets that child up for positive outcomes later on. So I see the perinatal period as an optimal time to address not only perinatal depression and anxiety, but any past depression or anxiety or past trauma that the birthing person has experienced, because you're interacting with the healthcare system at a higher frequency than many other times in your life, right? So it's such an opportunity to address existing depression or anxiety, but also past trauma.
I love that Kelly really lifted up how maternal mental health can play a role in intergenerational trauma. So that was great, great flag. So we're going to move on to our next question. We all know it's a politically very interesting time in our country. So would love to know from the panelists, how are your organizations preparing for and addressing potential federal Medicaid cuts and their impacts on maternal health services? So Kelly, I'm going to boomerang back to you. And I'm going to ask if you can also provide an overview of the current maternal mental health policy landscape in California, and what recent developments should advocates be paying close attention to?
Thanks. I feel like I'll be preaching to the choir when I say, if you look at that Mathematica study that says that every mother-child dyad that's untreated for perinatal mood and anxiety disorders costs $32,000 over a 5-year period. That's measured through like loss of work productivity, absenteeism at work, higher healthcare costs, higher social service costs, and so on. So the argument to invest in perinatal mental health programs is easy in terms of, if we invest in these programs, we will prevent these higher costs later down the road, right? What we're doing to respond to or to prepare for anticipated cuts is, well, luckily, maternal mental health now doesn't provide a lot of direct service. We provide a lot of training to the healthcare providers that serve the perinatal population. So we're doing the best we can, is what I can say. What I will also share, though, is that in the state of California, is really actually pretty far ahead of other states in terms of perinatal mental health policy. We've passed 2 state laws that mandate screening in the obstetric office, at least once during pregnancy and once postpartum. It also, another law requires birthing hospitals provide education on perinatal mental health to the patient, but also the providers. And this year, SB 626 is being considered. And what SB 626 does is it builds upon the past legislation by requiring all perinatal providers to screen, diagnose, and treat maternal mental health conditions in accordance to ACOG clinical guidelines. It also takes it a step further by mandating that healthcare plans cover mental health services during the perinatal period, that they provide some sort of case management. So once a patient is identified, that their care is coordinated throughout all the providers that they see. It also requires health insurers and service plans to report annually on the utilization and outcomes of maternal mental health services and to post that information publicly on their websites.
Information. Thank you for sharing all of that, Kelly. I'm gonna move on next to Sherry to talk about to respond to the question as well.
So we are moving forward with ramping up our maternal health and maternal mental health programs, but behind the scenes, our executives are actively planning for any potential cuts in Medicaid funding by the federal government. And the company really stands firmly behind the commitment to providing quality and affordable health care to all Medi-Cal members. Regardless of what happens, we will just do what we can.
Dr. Gant, would you like to reflect on this question as well?
Yes, this is kind of interesting for me because I am at the VA. So I am the federal government, they we follow everything. But I will say, like Ms. Sherry, our executive leaders are doing something a little bit different. They are very much in the process of making sure education is still provided and that we're not short-handing our women veterans at no cost. So what we're doing here is making sure that we implement education on both the social work side and all providers, our RNs and our NPs and our doctors. What we're trying to make sure is that we have screenings. We did not. So I'm really happy Kelly noted that, and it needs to be mandated that we need to have that because that was not happening. And then we're on the outpatient side of things, and when they're more frequent to come. Ladies or women are more frequent to come here for services. So a screening needs to happen so they are educated. Like Mia said, she didn't even know. And there's a lot of women who don't know. And we weren't doing our part to letting them know. So that is something that we're making sure we implement. Regardless of the cuts, we're still going to make sure we do our part.
I love that. We're seeing strong commitment on this panel for sure. And then Mia, I'm going to invite you to respond to this question as well, but I would love if you could maybe speak to it from the perspective of the role communication strategy plays in advancing a policy.
Yeah. So yes, things have been a roller coaster the last few months in kind of trying to keep up with what's happening on the federal level, trying to strategize what's our role. The nonprofit I work for, Maternal Mental Health Leadership Alliance, also called MMHLA for short. We are very niche and we focus on maternal mental health. But of course, Medicaid covers half of the births in this country. So we were like, okay, what organizations are going to be doubling down on Medicaid advocacy? How can we support this role? So we've joined a few coalitions that are, if there's like several coalitions, I don't know them all by name and the names are very long, but we've joined those to make sure that we're staying up to date on the latest developments, signing on to congressional letters, and making sure that we're communicating, our support for Medicaid as an organization and how it interconnects to the perinatal period and perinatal health outcomes. And then in terms of, sorry, I kind of lost my train of thought, but in terms of advancing policy and utilizing communications to do that, I think right now what we've been doing to prepare, since we haven't been doing direct messaging specifically about Medicaid, is we have been doing more work, more than we've ever done before, to educate our advocates, just everybody in our network about what is advocacy, their role in it, so that it doesn't, basically so that we normalize it more. I think there's been a disconnect for a lot of folks about the importance of civic engagement, of engaging in the government process and helping folks understand that they have a right to engage in what policies come forward, what policies are passed. The simplest way that I like to put it as a comms person is I say, your tax dollars are paying for the salary of Senator so-and-so and Representative so-and-so. They work for you, and you are within your right to communicate to them what issues you're seeing. And it's their job to come up with policy solutions. And it's your job to communicate with them about what is and isn't working in your community. It's a collaboration. And I think there's just been this icy brick wall in between us and the folks that get elected. And what I've been trying to do as a communications director is to break down that wall and to help everybody understand, whether they have a master's in public policy from Harvard or whether they're an everyday mom who's just trying to make ends meet and feed her kids, helping them understand their role in the government process. Because I think that disconnect has been fueling a lot of just like helplessness and a lot of confusion, and people feel like they don't know what to do. And so we really are trying to educate folks so that we can normalize and mobilize people so that when we say, hey, we really need you to do X, Y, and Z, call your reps about this, they already know what's coming down the pipeline. So there's been a lot of communication about what's at risk, what's proposed, what's coming down, trying to simplify the lawmaking process and how the budget goes from, the president to Congress to all these things, and trying to make it easy for folks to understand and access so that they can understand their part in the process, if that makes sense.
It absolutely makes sense. Just making the information accessible for folks.
Correct.
Yes, absolutely. All right, wonderful. We're gonna move on to our next question, and Dr. Gant kind of alluded to this. So I'm gonna start with you, Dr. Gant. How do we ensure maternal mental health is integrated into maternal care as a standard and not a siloed service?
I think first thing we can do, and what I try to make aware here, is that sometimes we want to like glass over it. We don't want to like acknowledge it. A lot of providers, so I don't want it to be invisible. This topic should not be invisible. So I try to make sure we provide education to our providers, like I mentioned, and our interns, whoever is a part of that interdisciplinary team. Everybody needs to know how to help our patients. So it starts there, but integrating screenings at the very beginning, we need to know what it is. Education has to be a part of it at the very beginning. We're not telling them at the end when they're inpatient or delivery. So those are some things we want to make sure it's in the outpatient and inpatient settings. We want to make sure that what I saw when I worked in the community at Arrowhead Regional Medical Center here in San Bernardino, they're doing a phenomenal job. Dr. Flores Kendra Carter, she is well known in maternal mental health in the IE area. She's taken her program global too, because she goes to Belize and does things there as well. But she was my mentor, and that's how I got into maternal mental health and understanding it. But what she did at Arrowhead Regional Medical Center is created a program where very first time a mom comes in, you even think you're pregnant, then that's when education is being provided immediately. So it started with just small literature until creating a video where moms were invited to like groups where they can learn about maternal mental health and wellness. When they're talking to their doula, making sure that they're culturally competent. So we just wanted, she took on a really like well-rounded whole person approach. So the videos, the literature, and just making sure that social workers or any mental health provider is there on those units. Most are not in the outpatient setting that I've seen. So we want to make sure that we are present, and so that we are providing this information. They're not being ignored, or even if they don't understand, like I mentioned earlier, how to acknowledge postpartum, or that I might be experiencing some symptoms, we can help them with that. We can educate you early on that, and then we could pick up on signs, because nonverbal communication is loud. So we can help on those things, and I think it comes with understanding what it is and having a mental health provider in those spaces.
Incredible. Thank you for sharing your experience there, and for lifting up your mentor as well. That's important. Okay, I'm going to move on to our next clinician, our other clinician on the call, Sherry. Would love to hear how you all are integrating maternal care as a standard.
Like Dr. Gant mentioned, we're also trying to educate the members as well as the providers. I mean, we know we send out a member handbook to these members. Do they read it? Of course not. I haven't read mine. So we want to make those resources available to the members. We have a number of community resource centers out in the communities where these members, especially the disparities, racial and ethnic disparity groups, are located. Those educational materials are available. We're encouraging these women to speak up. I didn't mention before, I was being treated for depression when I was pregnant with my son, my OB never once asked about depressive symptoms, never. And my family didn't talk about it. Nobody talked about it. I didn't know about it till Brooke Shields was on TV talking about postpartum depression. It's like, oh, this isn't normal for people. But we're trying to work with our members for a number of different angles, also the doula program. But my group in particular, we are focused on providing education to our providers who are seriously lacking in education and incorporating the tools into their treatment. It should be just like taking a woman's blood pressure or asking, what's your diet like? They should be doing these screenings and they're not. So we have sent out educational materials. We are trying to reach them. I mean, one tool that we have that I think carries some weight is we have these assembly bills. We have some of these APLs behind us. So when we audit, we go to these providers and they didn't pass the audit and we're saying, hey, you need to do this because of this, and we need to see what you're going to do about it. And then we audit them again to see if they did it. So yeah, I'm passionate about education. So.
Yeah. Yeah, and I have a quick follow-up question for you, Sherry. Can you tell us a little bit more about the program that you work on, the perinatal services program?
Yeah, we
And how
call it a
it's
comprehensive perinatal services program because that was our initial aim when we started putting this together in 2020. We thought that we were just going to be auditing CPSP providers who were part of the group, but we found there were only 19 of them, only 19. We don't really know why, but now there are a lot more. So we made a plan that we would audit our entire OB network over a period of 3 years. So we're still going now. We're still auditing, we're re-auditing, and we have new providers added. So we have nurses that are auditing medical records, and we emphasize education. And we really want these providers to know what it is they need to do. And another thing I did not mention is that we find that the providers who incorporate these tools into if they have electronic medical records, they build those screening tools, the PHQ-9, the Edinburgh depression scale. If it's in those screening tools in their records, they get to that question and they know to ask it. And we encourage the use of also, there are some printed forms. CPSP has forms, care plans, and visit forms. So we encourage them to use it. So it's kind of a reminder, hey, this is what I need to ask this woman now.
It's incredible. Thank you. Thank you, Sherry. Kelly or Mia, do you have any reflections on this question as well?
I'd like to share that Maternal Mental Health now is involved in a project called the LAMA project. LAMA stands for Los Angeles Maternal Mental Health Access Program. The PI, if you will, on the project is the University of Washington Ames Center, which is a sort of expert in integrated or collaborative care model. And so we're taking this model and applying it to the perinatal population at a handful of community clinics based in Los Angeles. What we're finding from this program, so the idea is that screening is integrated into every prenatal, postpartum, and pediatric visit. If based on the screening score, there's a warm referral made to the behavioral health clinician, which is under the same roof, same day. There's a consulting reproductive psychiatrist available to provide medication management advice to the prescriber if that's applicable. But what we're finding in this project is that only we're measuring how many of all the eligible patients that are screened or can be screened, how many are being screened. It's about 50%. And then what are the positive screening rates? It's about 3%. And we know that they should be closer to 20% or even more based on the population that these community clinics are serving. So I think provider education is a key factor in that. And not just education. I think that providers know I need to be screening, but comfort level. And I think a lot of providers are uncomfortable screening because there's a lack of referral resources. Even in this project, where there is a behavioral health clinician available immediately for these for the patients. And Another challenge or barrier is insurance, is billing, right? There's a collaborative care code, but we have spent hours trying to understand that and implement that so that the clinics are incentivized to do it, right? And the other point I want to make is I recently compared those statistics I just shared, the screening rates and positive screening rates, to the same statistics in home visiting programs in LA County. In home visiting programs are screening 98 to 99% of all eligible patients. And screening positive rates are 5%, so a little bit better. So home visiting programs are doing a great job of screening patients, slightly better job at eliciting an accurate screen. But the point there is that screening does not have to be relegated to the clinical setting. It can happen anywhere, anytime, at the copier, in the workplace, in the home visit, or even like at story time at the library, right? I think we all need to be aware of this issue and increase conversations around it. And when I say screening, it doesn't have to be an evidence-based screening tool, but just a conversation, right? One other piece of information from the clinic is that positive screening scores increased at the second or third screening. I don't have specific numbers around that, but what that does tell us is that the screening serves as an educational tool, right? As well, right? And so at the first screening, someone might be like, I don't want to share this information. I don't know you. I don't trust you, right? But as they continue to ask the same questions over a period of time, there's a trusted relationship that's built between provider and patient. So there's an argument to continue screening and to screen often.
Thank you, Kelly. There's some great promising practices you lifted up there. Multiple continued screenings, and also ensuring that the clinician, whoever is conducting the screening, is building rapport with the client, building trust. So the self-reported information is more accurate. So that's really helpful to know. Thank you. Thank you for sharing that. All right. And Mia, anything you would like to add?
Yeah, thanks, Rana. I want to jump in really quickly and say that we did a survey recently of our healthcare provider audience and asking them about the National Maternal Mental Health Hotline. And if anyone's unfamiliar, it's a 24/7 free hotline with trained counselors who are trained in perinatal mental health. So anyone can call, it's completely anonymous, call or text. And we asked folks, what their experience with the hotline was or how they use the hotline in their practice. And a lot of therapists and doctors and clinicians said that they offer it to their patients. And I know for me personally, I had a very negative experience with screening and then having a retaliative visit later on that wasn't warranted. And so I understand why people aren't, just screening once prenatal, screening once postpartum might not be the answer, especially for Black and brown people. And so the beauty of the hotline is whether or not you're sure if the patient or client or what have you is telling you the truth, you can give them the hotline, which is, oh my gosh, I'm going to blank on it. I say it every day. I think I'm going to put it in the chat, but I'm pretty sure it's 1-833-TLC Mama, but I'll put it in the chat later. And and we got some responses in our survey that some moms were like, I never called a hotline before. And I built a relationship with this person on the hotline. They would follow up with me. They connected me with a therapist. They would text me to ask how things were going. Like, this is a safe way that some of us who don't really have the privilege of accessing care safely all the time can access care a little more safely, and get a referral to a therapist without, having all of the racial profiling that can happen when you're screened in person, which happened to me. So I really want to throw that out there, that there are some clinicians that are leveraging the hotline in their clinical practice. And I love to see it because it's another way in for patients to get the help they need.
Yeah, that is an awesome segue to our next topic, which is focused on maternal health disparities. I think you lifted up some great points there around accessing care safely and some of the racial bias and profiling that happens in some of these care settings. We know mental health disparities are part of the continuum of birth inequities. So would love to hear from the panel. How are we supporting maternal mental health outcomes for Black and Brown communities and birthing people across California? Dr. Gant, I'm going to start with you.
Okay. So for me, it is huge that we acknowledge that Black and Brown women are often, I think their pain levels are minimized, their experiences are minimized. They're often overlooked. We're saying things, but you're not listening. So I feel like that is that's a lot of the reason why you don't see a lot of Black and Brown women seeking mental health services at all, because you're not listening to me. They don't feel heard all the time. So I feel like improving that trust factor, and the way we can repair that is just normalizing depression, I think, but also partnering with those who they do trust. So we know in Black and Brown communities that the church typically is where they seek refuge. Where if I'm feeling overwhelmed, most Black and Brown families, and that's just statistically proven, that they'll go to their church or some faith leaders, or just keep it within the home, somewhere in that nature where they feel safe. So I believe partnering with mental health and faith leaders, community leaders who have access to Black and Brown communities can also just share the information and normalize it. So when they go seek services, they don't feel ostracized, or they don't feel away like, I don't really want to speak, or feel like they're doing something wrong, if you will, or experiencing something negative. Because as a new mom, what you don't want to feel is that I'm not connected with my baby, or that I should be happy right now, but I'm really sad, and fighting that feeling, but not understanding that that's okay to feel. It's okay. Your body went through a whole lot, and for 9 months, and then even after the transition, I feel like that is not truly informed to them. They don't really know that. It's not normalized, and it's not being said that it's okay to feel these feels. It's okay to not feel. So I do believe understanding Black and Brown communities and partnering with those who have direct access, who can help normalize some of these things, because they're trusted partners for them. So that is huge for me. And that's what I've seen Dr. Flores Kendra Carter doing, is working with churches out here in the IE, and really spreading the word. And she works and where I met her, where I did my graduate and doctorate program, is at California Baptist University. So we have partnered with her, working with just other community partners, whether that's clinics, just prenatal clinics, churches, like I mentioned, just trying to really spread the word, and then normalize this illness. It's okay to feel this, and that's what we're doing. Just doing those things, normalizing it, and giving them the resources that they need so they feel comfortable.
I love that. Thank you. Yeah, it's okay to feel the feels. Normalizing that's important. Yes, yes. And Mia, I'm gonna boomerang back around to you this question.
Yeah, so one of the things that, at least there's so much good work happening in California, and I used to do some paid family leave advocacy, and I'm so passionate about how that plays a part into like postpartum recovery, but specifically for MMHLA in maternal mental health. I mean, we all know that there's not enough healthcare providers, mental healthcare providers, to meet the demand, and that there's even fewer who are trained in these special cases of perinatal mental health, which is like a whole nother basket, right? A whole nother can of worms. So one of the things that my organization has done over the years is secure federal funding to establish state-based programs. So there's 13 states, well, 12, and LA County, because LA is so big. So one of the grants went to LA County, and it funds a perinatal psychiatry access program. And what this is it enables any provider, you could be a midwife, a lactation consultant, a doctor, an obstetrician, a gynecologist, and you can call this psychiatry access line saying, I have a patient here, I screened them, they seem to be presenting with postpartum depression, postpartum anxiety, what have you. I'm not sure how to treat them. They're on maybe some other medications for ADHD, what have you. There is a trained psychiatrist who's trained in reproductive psychiatry who can provide guidance, consultation, referrals, and resources to whatever provider is with that patient. And what this does is it expands the capacity of providers to be able to treat patients. Because what we know is that there's an ethical dilemma that if you're a provider who isn't trained specifically in this perinatal mood and anxiety disorder, you might not want to screen, you might not want to ask, you might be scared to walk into that if you're not sure how to handle that patient and where to send them next. The psychiatry access line hopefully minimizes that barrier so that providers feel ethically confident in their decision to seek guidance and know what to do next. And this is helping fewer folks fall through the cracks. And so, of course, we would love to expand this program, this federally funded program, to every state in America. Right now, we started out with 7. I can't remember the number of states that originally applied, but it was a lot, and we only had enough money for 7. And then the next batch of money that came around from the federal government, we managed to do 12 states plus LA County. So every year, MMHLA advocates at the federal level for more money for these programs. And we just got word a few weeks ago that the programs are staying in the budget at level funding. So they're not increasing. We asked for more money. They're keeping it at level funding. But as you all know, right now with things being cut, we're like, yay, our programs are staying in. However, we're like, but also we need Medicaid, but also we need data and HHS not to be gutted. So we've been doing other advocacy outside of that to ensure that we're not, cherry picking the things that we want, right? The system needs to be whole. But that's one of the things we're doing in California to try to address those gaps there.
Thank you, Mia. I'd like to invite Sherry or Kelly to also weigh in, reflect on how we can address maternal health disparities in Black and Brown communities.
Start out. I say that we're kind of held to the fire on this one because we have to report to DHCS, Department of Healthcare Services, and this is part of their bold goals. So this is bold goals. This is our department goals, my personal goals. So we all have to do our part, and we have a number of different teams within the company that are working on this. DHCS wants us to reduce disparities, racial ethnic disparities by 50%. They said, outlined this in 2021 was their baseline year. By 2025, we were supposed to reduce it by 50% and increase screening of depression by 50% by 2025. And it's unrealistic. Let's just say it's a lofty goal. So we set an internal goal of 30%. And our baseline year was 2022 for our depression screenings in both prenatal and postpartum. Only 1% of our members in San Diego were being screened. 2025, we're up to about 28% prenatal and 32% postpartum. So we have to approach this from all angles. We have the doula program, which we're ramping up. The doulas, they can't do the screenings, but they talk to women. They can provide resources, education. We have population health management and working with case managers. We have a vendor who we've taken on to help us with a number of different things. And one is they're reaching out to members who don't show up for postpartum visits. Like we see a lot of women don't come in for postpartum. And this is another time that they can be seen and screened is when they bring those babies in to the pediatrician. A lot of providers don't realize it's in American Academy of Pediatrics. 1 month, 2 month, 4 month, 6 month visits. These PCPs are supposed to be asking the mom about depression, and we audit for that, and we don't see it at all. It's not being done because they don't have the time, they don't have the resources, the payment, the reimbursement for Medi-Cal, so forth. So we have a vendor who is doing telehealth visits for postpartum, and they can do the screenings for depression there. So, and I think First 5 LA, we have a group working with First 5 LA. They do in-home visits, which, like Kelly mentioned, seems to be much more effective at reaching these women. Yes, and I think we have now a incentive program for women who complete their postpartum visits. We're just going all out. Whatever's going to work, we have to try it. So.
Thank you, Sherry. Thank you, Sherry. I'm really curious about why home visiting is so much more effective in working with this population. Would love if anyone has insights there, can share a little bit more information.
I honestly think it's about the trust that's established when visitors have more time to spend with the birthing person, and as a result, they're able to establish trust and rapport. Whereas medical providers are like on the clock and incentivized to see many more patients so that they can bill higher. So that's why I think it's more effective.
Yeah, I think they're more comfortable in their home setting. And, I don't like going to the doctor's office. So I think, and there can be transportation issues. There can be other issues. I think it's just easier when somebody comes to you.
Yes, I want to second that. I personally experience a much better postpartum recovery experience when I received home visiting care. And having that therapist come to my house, come to my little apartment in Huntington Beach, um, I was more comfortable. My husband and I were sharing a car at the time, so I rarely had the car, and I remember that being an issue for other things. And then when I had postpartum anxiety, I was scared I was going to get in a car accident. I couldn't put my kid in the car without having a full-on panic attack. I mean, I'd have to change my shirt. I would get so sweaty just trying to get them to the car. So the idea of driving somewhere I've never been to go talk about feelings I don't even want to admit that I have, it wasn't ideal. So it's just, there's so many layers there. And especially, again, if we're talking about Black and brown populations, we're talking about people who might not have as many resources and things like that. It's really important to bring the care in. And also, every time I step foot into a doctor's office, my copay being $50, $60, not everybody has that. And I was already stressing about all the other appointments I was paying for. So having the home visiting program come to me, which was through the Orange County Parent Wellness Program, I didn't have to pay a cent. And then they were able to get me in because of that visit to, I think it was like 9 months of weekly therapy that was paid for through the program. Again, I did not have the money for therapy. And that's another reason why I didn't want to get screened, because I didn't want to be told I needed to go to therapy and pay again for something I couldn't afford. So them telling me we have a program, and I said, well, I can't do that because I can't afford childcare. I already had to drop therapy before because childcare was very expensive. And they were like, at the Orange County Parent Wellness Program, we have on-site childcare. And I wanted to cry. I probably did cry because now you're telling me I can bring my kid, I can drop them off in this room full of toys. They're so happy to be there. I can have a 1 hour break, talk to the therapist about my mental health, get myself together. That was a lifeline for me that second time around. So, yes to home visiting, yes to making therapy accessible, and all of the things. So, just wanted to give that take on it.
Thank you, Mia. I think you illustrated exactly the issues that Black and brown women and birthing persons are facing when trying to receive care for mental health disorders. So thank you. Thank you for exemplifying that. All right. I could talk to you all forever. I can't believe how fast this conversation moved. We have 10 minutes left, so I'm going to move on to our final question. And we really wanted to end with a call to action here. So our final question for the panel is, what is one action you would recommend attendees take to advance maternal mental health? And I am going to start with Kelly.
Well, building off Mia's comments earlier in the email I got this morning from Maternal Mental Health Leadership Alliance, you can meet with your representative next week. They will be home and ask them to continue to support the maternal mental health hotline as well as the perinatal psychiatric consultation programs.
Thank you. Sherry, why don't we go to you next?
I agree with reaching out to your representative, but there's still a lot of people who aren't going to do that. People keep putting that call 5 number up and, reach out. You can reach as many people with calling one number. But I think one thing that everybody can do is just talk, offer support. Nobody talked to me when I was pregnant. I mean, talk to your friends, talk to pregnant women that you see, just offer support and resources if you can.
I love that. Mia, we'll go to you next.
Well, Kelly stole mine. No, I'm kidding. I love that. Yay, the email is making the moves. Okay, but going off of what Sherry said, I really think I don't know about you guys, but I'm feeling some advocacy fatigue. The amount of emails where it's like threats, cuts, at risk in the subject, it's making my blood pressure go up. It's been stressful.
Yeah.
It's been hard. Yes, absolutely. Let's normalize advocacy. Let's build relationships with our offices. Let's be very much in the advocacy vein of things, but also let's build community more than ever. I mean, I know it can feel weird and awkward, especially since I feel like COVID took away all of our social skills. But every time I just ask a mom, do you want to come over to my house and can I make you a coffee? Like, I know you have a work and I have work, but just 1 hour. They're always so happy. They're so happy to have someone go with them. Or I have a friend who's always busy and like, I would love to run that errand with you and go to IKEA and help you put the pallets in the car. She would love that. We need to be with each other in the busyness and stop waiting till we have all this free time that never is coming to be there for each other. Because I know for me, one of the biggest things that was so hard in postpartum was the loneliness. I just felt so dang lonely. And, even when I did have paid time off, it was like, but everyone else had to work. So I just felt forgotten. And so reach out to your friends who are pregnant or just having a baby and come up with some sort of a plan to drop in on them once a week and just check in on them because it can make a huge difference.
That's great. Really tapping into the village, and it starts with that one-on-one human
Yes.
interaction and checking in with your family, friends, your community. Yes, absolutely. All right. And then Dr. Gant, we'll end with you.
Well, I'm going to start hanging out with Mia. So, recently, I just want to share. So I read an article last week, and it's an older article. It was written in 2020 by the the Surgeon General. And their call to action for maternal mental health was for women or moms to speak up and say something. I'm like, it just frustrated me. Like, well, if they knew how, they would. If you listened, they would. I mean, you would have done something a long time ago. So for me, my call to action would be to go out into my community. I am very much community organized. I love macro social work, so I want to go out and do the thing. I want to create the programs. I want to create the groups. So I am going to do more of that. I love doing it and starting that at Cal State San Bernardino because I have a lot of eager beaver social workers who love macro social work. So I think right now for me, it is jumping into the community and providing trainings and awareness to, like I said, community members. That is some things I'm really working on, is just working with the church leaders and other community leaders and just providing training for them, understanding how if this information comes across your desk, this is how you can refer. These are some people who are willing to come out and do the thing and to help. So that is just what I'm going to do, is just jump out into the community and partner with our community leaders and faith leaders, and then use my students to spread the word because they're so eager. So I'm going to just tap into my resources and really spread the word.
Thank you. Thank you all. I feel very uplifted, I think, on those calls to action. And we all have to be a part of the solution, right? We all have to be there for our friends, our family, mothers in our lives who may be impacted. So I love this. And so, Jana, are we ready for questions?
Yes, let's do it. I haven't seen
Okay.
any come in, but hopefully our participants have some they want to share with us. We've got a few minutes here, so please be sure to ask any questions of our panelist and our moderator.
I'm seeing a few in the Q&A. There's one
Okay.
from Kristen Hatton. It says, I'm wondering how we can really support and empower the birthing person. when they're already struggling with their mental health, since we're still in this major transition, which everyone here is navigating so admirably. I don't want to like jump in and take it. So I just, if anyone, I mean, I'm happy to say, to give my 2 cents. So Kristen, thanks for your question. How can we support and empower the birthing person when they're already struggling? I think, I mean, everyone is so different, right? Sometimes visiting someone who's struggling makes them more overwhelmed. So what I like to do is I like to offer a few options, be like, I can drop some food off. I can come and pay a visit. You can come to my place and I'll make you some coffee. Or, just trying to get an idea for how they're doing and like what their pain points are. And then just trying to listen, as Dr. Gant kept saying, listen, right? Because the way that you receive love and support might not be how they receive love and support. So to just ask questions, be curious and listen and let them know, hey, I have time and capacity and I just really want to be a friend to you during this season of your life if I can be of any support. And just letting them know that you're not a burden. I'm happy to help. Because yeah, if we just put on them this constant message of, well, if you're struggling, reach out for help. Well, if you're struggling, reach out for help, especially this situation with moms in their mental health, because it's like they're so focused. I mean, we're hormonally wired once we give birth to that baby to focus on that baby. We're not focusing on ourselves. So to have someone else that's focusing on that mom and helping them kind of figure out what they might need, or maybe you drop something off and they're like, I didn't know how much I needed this coffee or this in exchange, like it can make a huge difference. So I think really it just starts with that conversation, intentional and open, non-judgmental listening, and listening without like offering a ton of resources to solve a problem. There's nothing more overwhelming than getting 800 links when you're in the middle of it and all the Instagram accounts and just, just be there. Don't solve the problems yet. I know we're all like, we're really armed with information, but just be a friend first.
Yeah, I'd like to add that in my role, I get to go to different like meetings, convenings, conferences, and there's often people sharing their personal stories and their success stories. And the common denominator I hear in all those stories is that in their time of crisis, they had somebody walk alongside them, somebody who knew like what resources to reach out to, who had the wherewithal to follow up with a second, third, fourth option when the first two didn't work out, somebody to take care of the mom instead of taking care of the baby, but they all had that person who walked alongside them through that journey. And I honestly think finding that person currently is like a stroke of luck, right? And our challenge is how do we systemize that person to walk alongside each birthing person so that it's not a stroke of luck, that it's a standard of care.
Rana, can I answer? Not this question, but there's one in the chat that says, this might be covered, but I would love to hear more about PTSD as it relates to prenatal mental health. Miss Kristen.
Yes, please do.
Oh my
That's from
goodness.
Kristen Hatton also. That's a great question. Yes, please do.
Thanks, Kristen. Yeah. So I have a friend, my best friend actually just recently gave birth, and she did not have the best experience giving birth while delivering. And so, which caused a lot of PTSD for her, not wanting to go back to maybe that place, just feeling a little bit triggered. And I'm going back to the hospital, just not knowing. I believe, Kristen, in that same respect, having those feelings, sharing with your mental health provider or referring to a mental health provider for that mom, definitely that is all encapsulated into maternal mental health. That's all together, because your birthing experience can bring on depression, which can again lead on to PTSD, feeling like I don't even know if I want to go through that experience again. But not knowing that every birthing experience will be different, and having that supportive person, your doula, your RN, your provider, whoever is educated in that area, to give you a different experience to help you navigate those challenges and not minimize them at the same time.
Thank you, Dr. Gant. Very, very important question, Kristen. Thank you for asking that. And then we have one more question. Janet, do we have time to respond to the last question?
We're at the top of the hour, but if you want to, if y'all at the panelists have time, happy to, and then we can post the answers on the website. Go ahead.
Wonderful. Panelists, do you have time to respond to the last question? Okay. So this is from Becky Tyler. What do you see as the role of doulas in supporting maternal mental health? Also, if it takes three screenings to open up, do you see we need to increase the amount of times we screen?
I know we encourage at Blue Shield Promise, we encourage, we can't say that this is required because obviously it's not, but we look for screenings at every visit, every single visit. Yeah. And so I would say the same with doulas. Doulas can be supportive. You're going to see that for that mom or mom to be many times. Just keep that conversation open.
I think just to add on to Ms. Sherry that doulas play a huge role, especially because, again, Ms. Sherry already mentioned that they're going to see multiple times or that mom multiple times. So that trust is already being built. So I think the doula and having the doula be an opening or just a listening ear is a great thing because as a person you trust, you're trusting them with your whole birthing experience, So I do think that they're a great ally in maternal mental health because they are very knowledgeable about this process. They're not, they're not far from it. They're right there in the thick of things too.
Thank you, Dr. Gant. And I think with that, we'll close. I really appreciate all of our panelists today. I have chills from this incredible conversation. And I want to thank everyone in the audience for joining us today. I encourage you all, please check out the organizations represented today and check out the resources and links that were dropped in the chat. Maternal mental health matters, and together, collaboratively, we can help make a difference and improve outcomes and really hope to achieve maternal mental health equity. So thank you all, and I will pass it back to Jana.
Thank you so much. What an incredible panel. I was really excited about this conversation and knew it was going to be an important one, particularly for the month of May as we celebrate Mental Health Awareness Month. Thank you so much to Rana and to all of our amazing panelists. Really appreciate you. And thank you to our participants, our audience for being here today. Really appreciate your attention to this important topic. So want to just make a quick announcement. Would like you to register for our last policy forum at ITEP. We're going to be focusing on confronting social forces and driving incarceration. We focus on justice involved, and Cal aim for this next policy forum, which will be hosted on June 26th from 1 to 2. The link to register is in the chat, but you're also free to use that QR code to register for the policy forum. We hope to see you there. And again, a special thank you to Promise Health Plan for sponsoring today's event. Couldn't have been here without you. Thank you so much.
Thank you.
And feel free to sign up for our weekly newsletter and complete the evaluation. And both of those links are in the chat. If you need to stay up to date with ITEP, be sure to check us out on our website or follow us on social media. If that, I think we're done for the day. Thank you so much. Take care.
Thank you. Thank you. Bye.